let me see if I can move this chat box over somewhere. Okay, here we go. What I'll do is we'll sort of, I'll do the best I can to answer questions in the chat box as we go. I may fall behind. If I do, I'll catch up at some point. So, all right, let's see here. Let me try to get rid of this. All right, so we'll start with erectile dysfunction. You know, the definition of erectile dysfunction is the inability to achieve or maintain erection that's good enough for penetration. About 20% of guys that are older than 20 will have a little form of ED. You know, most people don't, but you know, we certainly see younger guys. Typically, it's a process that goes on with guys in their 50s, 60s, and 70s. At least half the guys in the United States, or even more, will have erectile dysfunction at some point in their lives. And about 40 million guys in the US have ED at any given time. Next. Next slide, Parker, if you can. There you go. So what's the erection process? You know, what I like to tell guys is all that an erection is more blood flow in than blood flow equals erection. So arteries in and veins out. As everybody ages, little muscles that pinch off the veins, which lie sort of around the outside of the penis, those atrophy. And so blood is allowed to seep out quicker than it can go in. It's a complex process that involves the arteries, nerves, and veins. What ends up happening in a natural erection is the nerves are stimulated when a guy is aroused, and those nerves will release a substance called nitric oxide, which therefore then dilates the arteries, allows more blood flow in, and then of course we have to have the venous end that's competent as well in order to keep the erection. Next slide. A lot of different things can cause erectile dysfunction. Obviously, aging is one, but I always tell people that, you know, diabetes, high blood pressure, high cholesterol, medications that treat all of those, prostate cancer treatment, obviously, is a significant one. We'll get to that in more detail, but there's a lot of reasons for it. Next. We'll talk about diabetes first. About 15 million guys in the US have diabetes. About half of those guys will have ED secondary to their diabetes. Typically, we start seeing ED start occurring in about 10 to 12 years after people are diagnosed with diabetes. Oftentimes, ED is a presenting symptom. Sometimes I'll have a guy that comes in with mild erectile dysfunction. I'll take a look at his urine and he's spilling a bunch of sugar in his urine, and I ask him if he's diabetic, and he says no. And I said, well, you are now at this point. So we try to work on that and try to get that straightened out for him. Diabetes. Go ahead and go to the next slide. Basically, we see a lot of problems with diabetes. We see problems with the eyes, we see problems with the kidneys, we see problems with the vasculature, and of course we see nerve damage. Diabetics will develop something called neuropathy, which is often in their fingers and toes, and that's a nerve problem. Well, if you damage the nerves, that's the first part of the erection that we just talked about. I always tell guys, look, we have 21 digits, 10 fingers, 10 toes, and 1 wiener. And and that can be affected just like any other digit. Quick question: does masturbation positively or negatively impact ED? Has no effect whatsoever. Not positive, not negative. And I always tell people, if somebody tells you they don't masturbate, they're lying to you. That's just my 2 cents. Not that I do, right? Next. Further issues that can cause ED in men with diabetes. You know, how long have they had diabetes? How old are they? Of course, because obviously you get the you get the age thing going too. If they're poorly controlling their blood sugars, if they're on other treatments like diuretics and other blood pressure medications, and of course if they have known cardiovascular disease. We'll get to a slide in a second here, but I always tell guys, the arteries in the penis are about the size of a piece of pencil lead in a mechanical pencil, whereas the arteries in the heart, which is obviously everybody's bigger concern, those are gigantic compared. They're 2, 3, 4 times the size of the penile arteries. So if we already have a guy that comes in and he's got known coronary artery disease, I guarantee you he's got penile artery disease because they're so much smaller. Next. Obviously, yes, diabetics are higher risk for heart disease. Typically diabetics, typically they're type 2, which means they're typically overweight. They typically have cholesterol issues. You develop coronary artery disease and plaques a lot quicker with diabetes. So it's dramatically higher risk for heart attack. And heart attack is, certainly the #1 killer of women in the United States, and it's up in the top 3 for men as well. Next. Next one, heart disease. So again, ED can be a warning sign of further issues. When I have a young guy coming in to see me, I always ask about his family history of heart disease. If I have a 32-year-old guy that comes in complaining of erectile dysfunction, #1, I'm going to look at him and see how is he in good shape or is he not in good shape? And if he's 32 years old, 5'10", and weighs 350 pounds, and he's on 9 medications, well, his ED is because of those other medical issues and the medications to treat them. And then he's probably developing some arterial disease. I'll always ask them about their family history of heart disease. If I can prove, which I can in the office using a penile Doppler ultrasound, if I can prove that a young guy has arterial dysfunction by doing that, well, that's cause for concern, and I'll actually have that guy see a cardiologist. Typically, though, we start seeing ED several years before we start seeing heart disease. Let's see. Question here: if you have neuropathy and it's causing ED, what's the treatment? Honestly, the treatment, treatment for the neuropathy is the treatment for neuropathy. If the neuropathy is from diabetes, you can actually, if you can, say you're a type 2 diabetic, and you're developing neuropathy, if you can reverse your diabetes, meaning like if you're type 2 and you need to lose 50 pounds, if you're to lose 50 pounds and get rid of your diabetes, you can actually have a small regression in the neuropathy. The treatment for ED secondary to neuropathy, though, is going to be similar. All the choices are out there. There's about a half a dozen things that we can do for erectile dysfunction, no matter what the cause is. And we sort of go from there. If it is diabetes, if it is neuropathy, again, I strongly encourage my guys, if they're a type 2 diabetic, here's how you would lose weight. I can send you to possibly to a weight loss clinic. There's, 30 of them around the city. Try to get off of all the diabetes medications, once you're not diabetic, that is, and you can actually see a little bit of a regression of the neuropathy. So I hope that helps answer that question. Next slide. So here's the artery slide that I like. The penile artery, it's only 1 or 2 millimeters across. Like I said, it's about the size of, it's about the size of a piece of pencil lead. Coronary arteries, obviously gigantic compared to that, 3 or 4 times the size of those. Femoral arteries, gigantic. So if a guy comes in and he has a known history of coronary artery disease, you can imagine if those gigantic vessels, that second one right there where it says chest pain above it, if that's clogged, I guarantee you the penile arteries are clogged. So we've got another question here. I'll go real quick. Can chemo treatments impact the ability to have an erection? Absolutely, because a lot of the chemo regimens, not only can they affect the vasculature, but a lot of them significantly affect the nerves all over the body. And so people that do chemotherapy often will come in and they'll develop neuropathy in their hands and feet. Well, they develop neuropathy in their penis too. A lot of those do go away once the people are off of chemotherapy. Some of them are permanent, though. So the answer to that is a positive. Yeah, chemo can certainly impact the ability to have erection. Next slide. Parker, I also noticed somebody was raising their hand a second ago. I don't know if we want to catch that one or not. I'm not sure who it was. I didn't quite catch it. How do you reduce your risk of ED? Well, lifestyle choices, diet, exercise, weight loss, stop smoking. It's always interesting to me when I see a young guy and he comes in and he's maybe a little bit overweight, but I mean, he smells like he's had a carton of cigarettes already. And he's like, I don't understand why I have ED. And I'm like, well, do you know what that does to your arteries? And again, we're talking about a teeny tiny little penile artery there. So again, any things that people can do to contribute to it. Now, having said that, that's not going to work for everybody, but a healthier lifestyle absolutely is going to reduce the risk long term for spontaneous or natural ED. Next slide. All right, we'll get to low testosterone here. All right, low testosterone, also known as hypogonadism. It's a decrease in testosterone. Depending on age, 30, 40, 50% of guys have low testosterone. I see this all day long. I see low testosterone. The symptoms that we see with low testosterone are going to be fatigue is a big one, decreased desire for sex, weaker erections, lack of morning erections, loss of muscle mass, and sometimes mild depression. So a lot of times I'll go over those symptoms with patients, and they'll just sit there and shake their head yes the whole time. Do you have any of these? And they're just yes, 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 yes. Simple test to do in the office. We don't necessarily treat a number. We treat symptoms. So I'll often see guys with what's considered a quote normal testosterone of 320 or 350, but they have every symptom in the book, and I'll certainly treat that. Let's see. Another question, no diabetes, no coronary artery disease, good LDL, still have neuropathy, then what? Non-smoker, not overweight. Yeah. So neuropathy, we'll have neuropathies that just, that can happen in general. People just can develop neuropathy with no other health issues. They just develop neuropathy, and those are unfortunate situations. Again, when I have a guy that just has a neuropathy, I'm going to treat him like any erectile dysfunction patient. We're going to get to every single treatment for erectile dysfunction here in a second. I'm going to go through every single one of them slowly. And so I treat that guy, and I tell guys, look, I know I can fix your erections. Essentially 100%. I always tell people 99% because nothing in medicine is 100%. But I know I can fix it. It's just a matter of with what. And it's a little bit of trial and error. And it's also listening to the patient and figuring out, number one, what has he tried in the past? What has worked, what has partially worked, et cetera, and then you move forward with that. Next slide. Again, signs and symptoms, fatigue, decreased energy, loss of muscle mass, depression, lack of libido, ED. Next slide. Quick question here. I had bladder cancer and had to go through regular checks. Tube inserted in the tip of the penis. I was told the testing could slow the flow when urinating. Can it also cause ED? Typically, office cystoscopy typically is not going to cause ED. It can cause some temporary slowing of the urine because it can cause some swelling in the urethra. If you have to have multiple bladder tumors resected, sometimes that large scope that we use in the operating room can cause some scarring at the tip of the penis. Unless they're resecting bladder tumors from very close to the bladder neck and getting very deep into the prostate, it's typically not going to contribute a whole lot to the ED. Next question is, and we'll get to this as well, this is another treatment for testosterone. I see ads claiming on TV that 90% of people with ED can be helped by non-invasive treatments to stimulate new vein development. Any truth to these claims? So that's going to fall under shockwave therapy, which I've been doing for almost 2 years. That works fine in the properly selected patients. The things that you see on TV, most of those clinics are, basically they're money-making adventures. And the criteria for shock waves in a lot of these clinics that claim that is you need a penis and the money to pay for it. I am fairly certain they do not even check a pulse. I certainly could shock every guy that walks in the office to the tune of $3,000 per person. My partners would love if I did that, but not everybody's a good candidate for it. And I can tell people, talking to them based on their SHIM score, which is Sexual Health Inventory of the Male, I can tell them about where I can get them with shock waves. And if it sounds good to them, we do it. If we don't, we don't. 50% of the guys that I see for shockwave consults don't end up getting them because I advise the guys, look, save your money. In fact, I had this discussion with my wife yesterday. about a med spa that she's sort of overseeing. She's a physician as well, and they got jacked up about doing something called PRP, which is platelet-rich plasma, which there's no evidence at all that PRP adds to anything. And you know, she talked to the guy that was billing it as this cure-all, and he said, "Oh, well, your husband's a surgeon, so he doesn't do that." And she said, "No, he does anything and everything that's available on the entire market that works for erectile dysfunction. I don't just operate on everybody. I figure out what works for the person." And she said, "Oh, well, he's got, you know, he's got articles that say that this stuff works." And I said, "Yes, and none of them are published in the United States. There's a reason that the true ED experts in the United States, none of us offer PRP. We do shock waves because we believe in that, and we've seen it work, and there are, you know, there are decent studies about that, at least in Europe. But as far as PRP adding to it, not much. Again, at, you know, $500 a dose, I'm sure they'd love everybody to get PRP. All right, one last one, and then I'm going to move on. Testosterone treatment after prostate treatment using radiation, brachytherapy, and Lupron. You know, that would be an individual person that I'd need to look at. If they were getting the Lupron just during their radiation and brachytherapy, like they got a year of Lupron, I would look at that guy and I would see, where is his PSA, how old is he, and how symptomatic is he? But typically, I will start, you know, post-treatment prostate cancer patients. If their PSA, if they are post-radical prostatectomy, if their PSA is undetectable and he's 6 months out post-treatment, I'll put him back on his testosterone. The radiation guys, that I'd have to sort of sort through and figure out, you know, was that just temporary Lupron, or what, are you still on Lupron? Or you know, exactly what that situation is. But I wouldn't, you know, as long as the situation was proper, I would put that guy on testosterone if he was symptomatic. A lot of ways to treat low testosterone. There are topical gels or creams, which are put on by the patients once a day. Patches, which basically is just a gel inside of a patch. The downside of the patches is the sticky stuff on them, the adhesive stuff. It really irritates people a lot. Oral medications are available. One of the ones that I use is Clomid, which actually stimulates your own production of testosterone. The oral preparations of testosterone, there was one called Striant, which is kind of like a Skull Bandit that you put between your lip and gum. Very difficult to get decent levels on those. So I don't use a whole lot of orals. Injections, which if we're going to do testosterone injections, I'll teach my patients how to do those typically once a week, or we offer pellets in the office, which we put in the fatty part of the patient's butt. It's a slow release or a timed release testosterone pellet. That's done about every 3.5 or 4 months. All of these are pretty reasonable. The cost of all of those are between $25 and $50 a month. So typically, so not too obtrusive. We had a question about are the slides available for download. That I'm going to have to leave to Parker if you want to reply to everybody in that. I don't know the answer to that. They were hard for me to get today. How about that? Next slide. All right, prostate cancer treatment. So here we go into prostate cancer treatment. So erectile dysfunction as a consequence of prostate cancer treatment. So if you look at the pictures there, you've got the bladder, and then you've got the prostate, and you've got the sphincter, and you've got the urethra. So the urine flows through the bladder, through the prostate, and through the urethra. The nerves that run the erections they're intimately associated with the backside of the prostate. And so no matter how hard we try, oftentimes those nerves, even though you try to spare them, it's not so successful. You know, typically when I see a patient, if I diagnose a patient with prostate cancer, number one, I tell them, look, I haven't taken out a prostate since I was a resident. I've got 5 partners that do a ton of them. So obviously you're going to be in much better hands with one of them. But I quote a 35 to 40%. And actually these are in the slides a little later, and I didn't even make these slides. So, 35 to 40% ED rate. And that can mean anything from you had normal erections, pre-op, and now you need, Viagra afterwards, all the way up to me needing to put a penile implant in that patient. Next slide. Oh, and by the way, that slide makes those nerves look gigantic. It's like those nerves lie in a web. It looks like a spider web when you actually do the surgery. So that slide, can you go back to that slide before, Parker? It makes those nerves look like they're gigantic. They literally are a web of nerves. I mean, you have to take them down in a sheath. It's not as easy as that slide makes it look. Next slide. So ED, yeah, again, super high rates of ED just in the population. The slide on the left, surgery, so 10 to 46% of guys. So like I say, I always quote a 35 to 40% rate of ED post-radical prostatectomy. I think that that other slide about radiation, I think that's a little generous. I typically quote 10 to 20% post-radiation. You know, but any treatment for prostate cancer, it's probably not going to help your erections much at all. And it certainly can hurt them. Lower rates with radiation, but it is what it is. Next slide. So Peyronie's disease, next slide. Okay, so what's Peyronie's? It is the development of scar tissue basically in the penis. It's typically from a minor injury during intercourse. Most guys do not know when they did it. They just come in and say, yeah, man, 3 months ago, I mean, it was straight, and then I got up and peed, and I kind of had a little bit of morning stiffness there, and I peed on the wall. It was going 45 degrees left. Well, it's this scar tissue, and what that's doing is it's scarring of the corpora cavernosum, which is the erectile body itself. And normally with the erection, the tissues thin out and they stretch. And sorry, that's my pig. He just came in. Silence. I'm teaching, Mr. Piggy. Anyway, normally they thin out and stretch, and of course they're going to be straight. Well, if you have adherence on one side, that side is not going to be capable of stretching to the capacity that, well, the other side is fine. So it stretches, and of course the penis then curves. The guys that I fix, you know, their partner complains during sex, or they just can't have erections at all. Peyronie's definitely contributes to erectile dysfunction because it causes an issue with flow distal to the plaque or on the head side of the plaque. You know, guys, especially when they're single, they have a lot of anxiety, you know, what am I going to do? You know, if I start dating a new girl, et cetera, et cetera. And so it can add stress to the relationship as well. Super common problem. At least 15% of the population has Peyronie's disease, and that's what we know about. There's probably another 10% or so that don't talk about it, or it's not bad enough to seek treatment or anything like that. Next slide. Okay, yeah, typically this just sort of comes on all of a sudden. The guy says, I swear a week before it was perfectly straight. Again, the plaques can typically be felt. Curve can go up, down, left, right, can cause hourglassing, etc. Again, yeah, ED as a consequence, causing problems with the flow, and it also causes shortening of the penis. Guys that come in with Peyronie's, the number that I hear over and over and over again is, I've lost 1.5 inches. So it's very significant. They can also have pain along with the curve. Sometimes they don't necessarily have to have curve. Sometimes they just have a painful plaque, and that can be in the flaccid state or in the erect state. Next slide. A lot of treatment options for Peyronie's disease, and I typically tell guys oral agents like vitamin E and Potaba don't do much of anything. When I do have pain in the plaque, I will use a medication called pentoxifillin, which helps with painful Peyronie's disease. Verapamil cream topically doesn't really do a whole lot, and it's been patented about 10 years ago. It used to be excuse me, about $15 for a tube. Now it's about $300 for a tube. Next, sometimes I'll do verapamil injections for I'm sorry, go back to the slide. Sometimes I'll do verapamil injections for very minor curves, little, 5 or 10 degree curves. Until about 6 or 8 years ago, that was really the only other option that we had was the verapamil. Xiaflex hit the market. So I've been doing that, I think, for 7 years now. It was April of 13, or maybe it was April of 14. I've done a lot of Xiaflex, several hundred guys. Honestly, when I see patients for a Peyronie's consult, One of the first things I ask them, of course, is, does it bother you or does it bother your partner? Because if they say no, well, you don't have to do anything about it at all if you don't want to. Xiaflex, I typically, with an upwards curve, I can get about a 50% improvement in curvature. Left and right, only about a 10%, down 0. So if guys are left, right, or down, I tell them, look, Xiaflex is going to be a complete waste of our time and money. Xiaflex is also really expensive. A complete course of Xiaflex includes, over the course of about 4.5 to 5 months, it's 8 Xiaflex injections with some other stuff. Each Xiaflex injection costs about $4,500. So we're looking at about $35,000 to do Xiaflex. So it's mostly covered by insurance, but still, you know, you don't want to just, you know, if a guy's not going to respond, you just don't use it, or I just don't use it. Penile plication, I do a lot of penile plications, which is just surgical fixation of the penis. Go back to the slide before, Parker, and one more. You know, so this guy, he's an upwards curve. What I would do for him is right about where it says corpus spongiosum, a little bit further back, I would make a little incision underneath that, and I'd go down to the erectile body, and I'd put 3 or 4 stitches in the bottom side and just flex that forward and can straighten the penis out. Average improvement for a penile plication is 90%, and those typically take me about a half hour to do. When you read, you can go forward 2 slides. When you read about plications, or if a person reads about plication, they always read, oh, you'll lose length if you have that done. The truth of the matter is the length has been lost from the Peyronies. Those guys come into my door and they say, I'm 1.5 inches shorter. If you fix it, how much shorter am I going to be? And I say, you're going to be 1.5 inches shorter than you were. I'm just going to match the sides. Sometimes I'll take the plaque out and I'll put a graft in. You don't gain as much as the internet tells you from grafting. It's a much, much more difficult recovery than just a simple plication. Simple plication, the guy typically is having sex within 6 weeks. A graft, if a guy tells me he has sex within 4 months, I'm surprised. And then, of course, penile implants. We can, if a patient has both significant erectile dysfunction and Peyronies, I can put a penile implant in them and fix both in the same sitting. Next slide. Options for treatment. A lot of options for treatments. They go from low to high: oral medications, vacuum pumps, urethral suppositories, penile injections, penile implants, and I'll also throw in shockwave therapy. Somebody asked about it earlier, and like I said, I've been doing shockwaves for about 2 years. We don't have any slides on shockwaves, so I'll sort of do that first. Basically what shockwaves are is it's 6 treatments typically, and we put numbing cream on the penis and we shock the entire length of the penis 12,000 times. It's ultrasonic shockwaves. And we start between the legs and we work our way up to the head. The design of it is to gently damage the arteries in order to allow them to heal themselves, which allows expansion of the arteries, and it allows creation of new arterioles. So it's like a revascularization procedure. If you were to Google a SHIM score, S-H-I-M, the guy's score, it can be 1 to 25. 25 is perfectly normal erections. 5 is just nothing. The guy has no erections. The perfect guy for shock waves is about a 13 or a 14 up to about a 21 or 22. What I do is I actually classify guys in order to pick them out for shock waves. I'll classify guys as normal erections, success with pills, struggles with pills, success with injections, struggles with injections, and really needs a penile implant. Typically, I can add about 5 points to a guy's SHIM score, okay? And so if a guy's a 20 and I can make him a 25, well, he's got normal erections. Well, that's a guy that would come in and say, you know, pills work for me, but I want to get off of them. Well, shock waves, I can probably get him off of his pills. If a guy comes in and says, these pills used to work for me, but I'm really struggling, and his SHIM score is about 15 with the pills, I could probably get him to a 20 where he'll be happy again with pills. And it typically lasts for about 2 to 3 years. There's a big gap between success with injections and struggles with pills. And this is where I have pretty long discussions with patients. The guy's been on injections for a while, and I say, you know, when was the last time you tried pills? And he'll say 5 years ago. I say, well, it'd be great to see how you do with pills today, because if you have so success with them, then shockwaves are appropriate. If you have zero success with them, then the best that we're going to hope for in that situation is we do a shockwaves on him and we get him to struggling with pills. Well, he's not really going to be happy. So that's kind of a guy that I'll talk out of it and tell him to save his $3,000. It just seems fair to me to be transparent with patients. That's what they expect from me, right? Next slide. Okay, so pills: Viagra, Levitra, Cialis, Stendrastaxin. 5 of them on the market. Cialis, and we got another hand raised there. If we can have Randy, see if we can have him type his message real quick. Cialis and Viagra have gone generic in the last 2, 3, 4 years, so they're available as tadalafil, which is Cialis, and they're and sildenafil. They're very expensive. Most of the time, you can get them for 50 cents, $1, $1.50 per pill, ballpark. So much, you know, very, very reasonable. Obviously, the absorption can be affected by food. I typically quote about a 50% effective rate. That's just all comers. You know, if a guy walks in with mild ED, he's going to do great with pills. If a guy walks in and hasn't tried pills or hasn't tried to have sex in 10 years, he may not work. Question is a shockwave covered by, let me see, Medicare? No, shockwaves are not covered by any insurance, strictly cash, not FDA approved yet. As papers come out by US urologists, what will happen is you will see eventually that it will be FDA approved. Probably going to be at least 3 years, if not 5 years. There's currently a pretty large clinical trial that I was asked to participate in, but I didn't like the way it was structured. You know, the participants in it. And I told the guy that was organizing it, I said, the participants in this need to be ED experts. You can't get the guy that's a plastic surgeon that's doing shockwaves and get him to contribute to this paper. But anyway, so eventually, but not now. All right, next slide. Side effects: headache, stuffy nose, flushing, backache. Don't want to mix them with certain medications. Nitrates for chest pain, they can really dramatically lower your blood pressure. Same with alpha blockers like Flomax or Alfuzosin. If you put those together, it can dramatically lower your blood pressure. Obviously, if you had heart problems or stroke, et cetera, we want to know about that. If you have a cardiologist, we'll talk to them, et cetera. Next slide. Vacuum device. So vacuum device is just a a hollow plastic tube. You put the penis in it, you put it at the base, you apply suction, it sucks blood into the penis, makes it stiff, and then you can see there's a little ring at the bottom of the guy's penis there that holds the blood in, basically acts as those veins that we were talking about earlier. The pumps are battery operated or hand pumped. They work. Satisfaction rates down here, I told the guys that put these slides together, I quote a 30% satisfaction rate on vacuum devices. You know, they work, but most of the time they're maybe a little uncomfortable. The ring is too tight, and those are reasons for guys to drop out. So I tell guys, 30% of guys will get one of these and they will use them forever. 70% of vacuum devices, in my opinion, are in the back of somebody's closet not getting used. But it's an option. So common issues: blocked ejaculation from the ring, a little bit of bruising if you overdo it. The penis does feel cold because there's not blood circulating in and out. Most of the time, the reason for discontinuation is going to be discomfort, or I can't quite get it hard enough, etc. Next slide. Urethral Suppository Muse. I used to use a lot more Muse when they sampled them. This is prostaglandin E1. And so basically what you're doing is you're sticking a little stick down the wiener, which is, yes, it's not terribly comfortable, and that absorbs through the urethra into the erectile body. I typically quote about a 40% success rate with those. Downsides are you can have some burning, vaginal burning, can lower the blood pressure. The other downside is they're about $50 a piece. Again, when I used to be able to sample them, I use them a lot more. I kind of brush over them because most guys are not going to be jacked up about a $50 per insert price tag. And some of the side effects, but it's an option as well. This is one of the components, prostaglandin E1 is one of the components that we'll talk about that are in injection therapy in just a second. Next slide. And here's injection therapy. So Caverject is a name brand one, which is pure prostaglandin E1. I typically use Trimix, which can be made at a compounding pharmacy. Again, it's a lot less expensive for the patient that way. It's a combination of prostaglandin E1, papaverine, and phentolamine. You give yourself a shot about 10 minutes before sex. 60 to 80% of patients, typically I tell people 80% of patients it will work for. Not everybody continues it. You can have a little bit of discomfort. If you overdo it, you can have what's called a priapism. You can have a little bit of bruising, etc. These are fairly cheap, and I demo these in the office. I show guys how to do them, see what they get, and then I prescribe the appropriate concentration for them to go home with. I think that's important. I think people that just write prescriptions for the stuff and they're like, just go home and try it, that's a little dangerous. That's the guy that'll be in the emergency room that night with a priapism. Having a 4-hour-long erection sounds like a great idea until you have one. It's really, really not comfortable. But these are easy. And I typically tell people, look, the needles are about the size of an eyelash. You have very little sensation on the side of your penis. At any given moment, I've got probably 200 guys on penile injection therapy. Whatever works for them, I'm happy with. So I find what works for the patient and we stick with it until it doesn't work. Next. Implants. So do a lot of implants. This is for a guy that's, refractory to everything else or not willing to do it. I mean, sometimes I have guys, I'm like, hey, let's try shots. And they're like, you have lost your mind if you think I'm going to give myself a shot. But these are simple devices. They've been on the market for over 40 years. It has 2 cylinders that go into the penile shaft. It has a pump that goes in the scrotum and a reservoir that goes up top that holds about 2 ounces of sterile saline solution that runs the system. When the guy wants an erection, he squeezes the pump about 15, 18 times and it fills the penis with saline solution instead of blood. When the guy doesn't want the erection anymore, he squeezes another button and the penis comes down. I tell guys you can leave this up for 10 minutes or 10 hours. I do these as an outpatient. I make about a 1-inch incision above the penis and go down to the erectile body. I measure to put the appropriate size device in that patient. Pump goes down in the scrotum, reservoir up top. I send the patient home the same day with a wrap on and a drain in. I see him back the next day. Take the wrap off, take the drain out. Most of my guys have very little swelling. That drain takes out a lot of the swelling that would have happened before. Once I take the drain out, I tell guys, look, you're going to swell up some now. See them a couple weeks later, make sure they're getting the pump down. About half of my guys are able to pump it up and take it down by the 2-week visit. Then I see them at about 5 or 6 weeks. 90% of my guys are able to put it up and take it down by the 5 or 6 week visit. Let's see. 10% of my guys have used the device for sex by 2 weeks, which I think is a little ambitious. I think you'd be a little bit too sore. 50% of my guys have used their device by the 6-week visit though. High satisfaction rates, way better than 90% patient and partner satisfaction rates. Partners typically say it feels natural. Sometimes it's so hard that the partner will say it feels unnatural. And so I ask the guy, leave it 2 or 3 pumps short so it feels a little bit more natural. I actually have one patient, I put his in, it's been about 3 years ago, and he has been dating the same woman now for about 1.5 to 2 years, and she still doesn't know that he has a penile implant. He's never told her. She felt the pump one time, and he said, oh yeah, I've got a cyst on my testicle. It's benign, don't worry about it. All she knows is he's like the best lover she's ever had in her entire life. I still think I'm like, I cannot believe she has no idea. And he's like, I'm telling you, she doesn't. Yeah. Next slide. Little video here. Maybe. Imagine a guy pumping his scrotum and his penis is going up magically. Oh, there we go. All right. Implants are a permanent solution for erectile dysfunction. It does help with spontaneity. Typically, most guys can put their implant up in under 30 seconds. It stays up as long as you want it, totally contained inside the body, so you can travel with it. It's not going to set off airport metal detectors. Very high patient and partner satisfaction rates. Most of my guys, 90-95%, have no issue with orgasm. They've been put in for more than 40 years. Over 500,000 have been placed. I personally have put in a little over 800 of them in my career, so quite a number of them. I remember when I was real young, I used to remember every guy. Every now and then I see guys and I'm like, oh, that's a good looking implant. They're like, yeah, you put it in 5 years ago. Oh, okay. Sorry, I forgot. Next slide. I'm just getting old. That's why I can't remember everybody. All right. So risks, so I typically tell patients risks. Okay. So it's surgery. You're going to have a little scar above the penis, infection, but less than 1%. You're going to be sore for 2 to 3 weeks. And I tell guys, look, you're going to hate me for 2 or 3 weeks. We lose a little bit of length. What I tell guys is I'll actually take their penis and I carry a ruler in my pocket. And yes, I clean it with alcohol between patients. And I stretch the penis. A natural erection thins out and stretches. An implant erection just stretches. So I can actually measure a guy in the office and I can say, okay, you're going to be 5 inches. To which most of the time they'll say, well, normally I'm 6. And I'll say, okay. What I do like to use is I like to use by Boston Scientific or AMS, a device called the LGX. It's called the AMS 700 LGX. Stands for length girth expansion. As many of these as I've ever done, I've never had a guy come back to me and say, Doc, you made it too big. Like this is like it's entirely too large. But you do have guys come back and they say, well, I could use a little length. So at the 6-week visit for those guys, I send them home for 6 months and I say, look, whether or not you're going to use this, I want you to pump this thing up as hard as you possibly can and leave it up for 15 minutes a day. And we stretch and we're going to gain back 1/2 to 3/4 of an inch of length and 1/8 to 1/4 inch of girth. So at the 6-month post visit, the guys come in and they're like, all right, this looks a lot better for me. The devices typically last about 10 or 12 years with normal use. It's really about it, I think. Are implants covered by Medicare is a question over here. Yes, they are. So Medicare covers 80% of the cost, and most of my guys that have supplements as well, which most people have, those guys will get out of pocket for $0 to $500 for the implant. Just to give you an idea of cost of these, the implant, if I do one for cash pay, that's the implant, which is at least 2/3 of the cost. Surgery center, anesthesia, and my charge, it's about $19,000. Okay, but yes, they are covered by Medicare. Next slide. So ED is common, like we talked about. A lot of treatment options. So I just talk to the patient and I tailor it for him. Can be a permanent solution. It's got to be a couple's decision. Talk to an ED specialist, really a prosthetic urologist. Basically, a prosthetic urologist is a guy that, a significant amount of his practice is putting in implants and taking care of erectile dysfunction, like myself. Do giddy penile rings work? I'm thinking that is just a cock ring. Let me look that up real quick. I'm thinking that's just a cock ring. And the answer is yeah. I mean, if you have a venous leak, any kind of ring will work for you. Let me just look up the giddy. I've heard of that before, but I don't remember off the top of my head. See if I can pull it up here. Giddy ring. Giddy rings. Oh yeah, so yeah, that's get me giddy. Hang on. Yeah, so that's basically that's just a ring with a clamp in there, the Giddy penile ring. So yeah, sometimes if I have a guy that has venous leak, I'll actually tell him cut the tip of a condom off, and you can actually use the rolled up condom as a ring. Giddy rings are fine. You know, that's just a guy that you got to have good enough arterial flow, and the issue is venous leak. Using a ring at the base, kind of like you'd use with a vacuum pump, those will work. Typically, rings are anywhere from $5 to $25, and it certainly can be tried. You put it on, after you've got a good erection. So the guy that has venous leak, what he'll tell me in the office is he'll say, I can get a good erection, I just cannot maintain it. That's venous leak. I can prove it with ultrasound, but I tell the guy to his face, you've got venous leak. Let's see. In the end, would you address, are there anything for women to increase libido and sexual desire? I will do that, absolutely. And the answer is yes, for female sexual desire. Next slide. Actually, let's talk about that real quick, because I'll forget. We already talked about testosterone. So yeah, women, female sexual desire. Obviously it can be multifactorial. Sex for men and women is different psychologically. Guys, we need to see something that's attractive and we want to have sex with it. That's basically how basic we all are. Okay. Women, there's a lot more emotion. There's a lot more setting, if they had a bad day, different things like that. So there has to be, it's a conglomeration of things. In general, when I have women that will come to me, and they'll say, look, I love my husband. We have a great relationship. Life is wonderful. We're both retired. I have zero desire for sex. Well, she eliminated most of the, essentially all of the other stuff. She just told me my relationship's great, all these things. I'll actually I put a lot of women on testosterone. Not as much as I put men on, but a pretty good amount. And I'll get a female's testosterone level up to 150, 250, sometimes 350. And that gives them better desire for sex. There's a new drug on the market. I can't remember the exact name of it, which is supposed to just be a pill for sexual desire. I think the effective rates of it are low to medium, but typically with women, if you put them on testosterone, again, as long as everything else is okay, their sexual desire will be better. For instance, let's say a woman's in an abusive relationship, and her husband has her come in, and she says, "Yeah, I don't ever want to have sex with my husband." I put her on testosterone. She's like, "I still don't want to have sex with my husband because he's beating the crap out of her every night." Well, of course she doesn't want to have sex with her husband. Those are the types of things that I would say are going to affect it. But in general, yeah, testosterone is most of the time a good answer for that. And again, very reasonably priced, inexpensive as far as testosterone treatments for females. All right, stress incontinence. Next. All right, so, stress incontinence is, leaking of urine. You laugh, you cough, you sneeze, you push yourself up, you bend, you leak urine. Prostate cancer treatments, I typically quote 10 to 15% will have bothersome stress incontinence, which you can actually see this slide says 9 to 16, so I'm right on there. A lot of guys have that. There's a lot of prostates that are taken out in the United States every year. About 180 to 200,000 new cases of prostate cancer a year. About 60 or 80,000 radical prostatectomies are performed. If you do the math on that at 10%, you got 6 or 8,000 guys that will need a procedure to fix their urinary incontinence if they so choose. Not every guy does. I've got some guys that leak like sieves. They're wearing a half a dozen pull-ups a day. They leak all their urine, and they're like, whatever, it's fine. No big deal. Okay, it's totally up to you. Nobody's ever died of stress incontinence. It's just really bothersome, and you can get really rashy. Next slide. So the bladder stores urine, goes through the prostate and urethra like that other slide. The sphincter, which is just below the prostate, the external sphincter, that's the main mechanism of continence. That sphincter stays closed at rest. And when you want to pee, it relaxes and opens up and the patient can pee, or the person can pee, I should say. During prostate surgery, that sphincter, again, on this slide, it looks like they're pretty separate and pretty obvious, but that sphincter, it's actually almost inside of the prostate. And so when the surgeon's doing it, they actually have to dig sort of into the prostate and pull some urethra out in order to spare as much of that sphincter as possible. Again, 10 or 15% of guys will have incontinence. And I tell people, look, when I was doing prostatectomies, and I did exactly 100 radical prostatectomies as a resident, which is, I don't know how in the world it happened to be 100. You do the case the same way every time. And we would do these beautiful dissections and spare the nerves and have this great stalk of urethra, and we'd put it back together. And I'd say, that's the best prostatectomy I've ever done. And the guy couldn't get an erection to save his life, and he leaked like a sieve. And then the next one we would struggle, and the guy's bleeding, and I can't see the nerves, and we're just trying to get the damn thing out before the guy bleeds to death. And we put him back together, and I'm like, that's the worst prostatectomy I've ever done. I go in the room the next morning, the guy's got an erection in the bed with a catheter in. We take his catheter out, he doesn't leak a drop. And you're like, how in the world does that happen? But the surgery is typically done the same way every single time. Next slide. Again, 10-15% of guys will have post-prostatectomy incontinence. I do see patients with neurologic disorders, spinal cord injuries. Old-fashioned TERP carries about a 1% incontinence rate. Radiation, I typically quote about a 2 or 3% of incontinence after radiation. And then, of course, pelvic trauma. Sometimes these guys will have pelvic crush injuries, and the bone in the crush will actually damage the sphincter and the neural activity in the pelvis enough that the patient has incontinence. Next slide. Next. Oh, I blew these slides. 180,000 guys, or 200 a year, 70 radical prostatectomies, 10 to 15%. Again, you got a lot. In my practice, 400 to 500 prostates a year are taken out. So 50, 75 guys have bothersome incontinence, ballpark in my practice. I see most of the guys from around Austin, most of the urologists around town send all this stuff to me just because I've got my system and they know I'll deal with it and send the patient back to them. Without stealing their patient. Next slide. Normally, yeah, it's not unusual for a few months to have a little leakage, but it can recover. We do typically reserve about a year post-prostatectomy. If I see a guy, like I saw a guy recently, and he was about 8 months post, and he was leaking terribly. And he's like, should we wait the other 4 months? And I told him, that's up to you. You're not going to get dry in the next 4 months. If he was close, if he was leaking an ounce a day, I'd say, man, let's not do anything. Let's see. Question here. If you've had a urolift, can you be considered for an implant? Yeah, absolutely. Yeah. Typically, well, honestly, almost anybody's a candidate for an implant. I was going to say, I can't think of a reason why I wouldn't. I mean, I've put these in guys with kidney transplants, heart transplants, pancreas and kidney transplants, post-radical prostatectomy, post-cystectomy and creation of neobladder. The hard ones, the real hard ones, are a guy who had an implant, got infected, they took him back, tried to salvage him, put another implant in, it got infected, and then they took it out, and now it's 2 years later, and he's like, can you put my implant back in? The answer is yeah. It's just going to be really hard. But yeah, absolutely. Urolift, absolutely. No contraindication there whatsoever. Next slide. Male continence options. Behavioral modification. A lot of guys will figure out that if they reduce their fluids, they reduce leaking if they go to the bathroom more. I actually had a guy one time, he came to see me, and I was going to put a sphincter in him. He was leaking like crazy. He calls and cancels his surgery, and he sees me whatever, a few months later, he said, man, I figured it out. He said, I limit my fluid intake to 8 ounces of fluid a day and I don't leak. And I said, man, does that ever become problematic? He said, well, I'm thirsty a lot, but he said, and I've passed out on the golf course a few times, but other than that, no, it's gone fine. So eventually I put a sphincter in him. Pelvic floor physical therapy, Kegel exercises, biofeedback. That's the PT that we often start before surgery. That can get a lot of people there. You got to remember 85, 90% of guys will get dry. So that can get a lot of people there. And then you got coping mechanisms like pads, diapers, catheters, which are not ideal. Penile clamps. Some guys refer to those Cunningham clamps, like down at the bottom. I've heard guys call them the geezer squeezer, which I love that term. It's hilarious. Of course, I'm becoming a geezer, so I don't know. Next slide. Another question: if Peyronie's disease is an implant, a good solution? Yeah, I mean, an implant's a good solution for Peyronie's disease, assuming the guy has significant erectile dysfunction. If a guy comes in and he has totally normal erections, but oh, by the way, it's curved up 45 degrees, well, that's not a good implant guy. But if a guy comes in and says, look, I'm using these big doses of this injection of Trimix, and by the way, I've got a 45-degree curve, then that's a guy. I'm like, well, you're struggling with the shots anyway. Let's put an implant in you and I can fix both. So it kind of depends on that situation of that Peyronie's person. It certainly works. Typically, unless it's just awful Peyronie's, typically I can put an implant in and I can get that guy's, without doing application at the same time, I can get that guy's curve straightened out by 50 to 70% by just putting the implant in and flexing it. Treatment options for incontinence. There's 4. I always tell guys, look, you don't have to do anything. Nobody's ever died of incontinence, but you probably wouldn't be in my office talking to me about your incontinence if it didn't bother you. I like to classify guys, and I'll actually have them, oftentimes I'll have them weigh their pads for a week. Basically weigh one of their pads dry. Typically it's going to weigh like an ounce. And then as they come out, weigh them on a little kitchen scale. And then they do the math for me and I see how much are they leaking in a 24-hour period. And I want to see how they do over the course of a week, because I want to see their good days when they're just kind of taking it easy, watching TV or watching football. I want to see their bad days where they're cleaning the garage and washing the cars and doing all this stuff. Yes, gumbo. Okay. Sorry about that. Life is still going. Life is still going on at my house. So anyway, so where was I? Leakage. I have them weigh their pads and see how much they leak. I classify guys as mild, moderate, or severe based on the amount that they weigh in their pads. I was saying their bad days. If they're real active, they're going to leak more, obviously. I want to fix the bad day. If I fix the bad day, well, of course, the light days are going to be, he's going to be dry. So I classify guys as mild, moderate, and severe incontinence. Mild incontinence is about 1 ounce a day. Moderate's about 2 to 6 ounces a day. Severe is more than that. Will you go away? I'm giving a talk here. He does say he wants to be a urologist, though. He's 13 this past weekend. Okay, thank you. Okay, go on. I'll call you when dinner's ready. So mild, moderate, severe, 1, 2 to 6, and more than 6. Mild incontinence, I'll recommend either injections of coaptite, which is made by Boston Scientific. It's an injectable. If that guy's leaking a 1/2 ounce a day, 1 ounce a day, I can put some coaptite in there, bulk up the urethra. Works about 40% of the time. It can be repeated. A sling, the new Advanced XP sling by Boston Scientific AMS, very good device. It really latches in really nicely. No screws. It just incision in the perineum underneath the scrotum. I put the sling on the sphincter, and then I pull the arms up through the groins, and it attaches through the tissues in the groins and lifts the urethra and puts compression on the urethra as well. So mild, I'll use either a coaptite or a sling. Moderate, I'll use a sling, or I'll use an artificial urinary sphincter. Artificial urinary sphincter is basically an inflatable mechanical device. There's a cuff that goes around the urethra. So I make an incision underneath the scrotum. I go down the urethra, dissect around the urethra. I measure and put the appropriate size cuff on that patient. I make a small counter incision in the groin area. I put the reservoir that holds about an ounce of saline solution that runs the pump, and I put the pump into the scrotum. I do those as an outpatient. I send the patient home the same day, see him back the next day, take the catheter out. It stays one night. Take the catheter out, make sure they're peeing okay. See them 2 weeks later, make sure they look okay. See them 6 weeks out, turn on the sphincter and teach them how to use it. Average improvement rate is about 90% on those. I typically tell guys, hope for 100, but expect 90 and they're happy. Slings, 60 to 75% of guys are dry when it's appropriately chosen. Guys that are severe, if a guy comes in and his pad weight shows me he loses 30 ounces of urine a day, I tell him, look, pardon the pun, but we're pissing in the wind if we do coaptite or slings. You really need a sphincter. And so that guy will get a sphincter. Next slide. Sling, minimally invasive. I don't like this one. Normal activity is resumed in 1 to 2 weeks. I tell guys, look, you're going to be pretty dang sore for a couple of weeks. I see that guy at 3 weeks to see how he's doing. Typically by that time he can tell me, hey, yeah, I'm very improved. I'm, leaking 2 ounces a day now. This is great. Or, I was leaking 9 ounces a day before because he wanted me to, go for the gusto and try to put a sling in him, which I will push the envelope. I'll talk to the patients, and if they're 10 or 12 ounces and they say, I really want a sling, can we do that first? I say, yeah, we can always go back and put a sphincter in later. But I ask these guys not to do anything real heavy for 6 weeks after a sling to make sure that sling actually connects itself to the urethra. There's no interaction with the device. You don't have to use a pump or anything like that. So pretty good deal for those. Next slide. Artificial sphincter, it acts just like a healthy sphincter. When you want to pee, you squeeze the pump, opens up, and you can pee. It's all inside the body. It's undetectable to others. Will not set off airport metal detectors either, and no electronics involved. I had that question come to the office today, a guy that's on the schedule for a sphincter. He said, there's no electronics in this, right? Because I've got some people that would think, I got some friends that would think it'd be funny if they could hack into it and make me pee myself in Costco. To which I said, I think that's pretty funny too, but no electronics involved. Next slide. So artificial sphincter, cuff around the urethra, reservoir up top in the groin, up above the pubic bone, pump in the scrotum. When you want to activate it, you just squeeze that pump a couple of times and it pumps the fluid out of the cuff into the reservoir. Urine can flow, let it go, and the reservoir slowly squeezes that closed again, and you walk around with a closed sphincter. Next slide. Obviously, if you're bothered by your leakage, seek help. You don't have to live that way. A lot of options for leakage. Next slide. Risks involve pain, bleeding, infection, scar. Foreign body response is pretty unusual. Typically, the body will just encapsulate these devices. Urinary retention, not being able to pee after a sling or a sphincter, very rarely, but it does occur. As far as device malfunction, with a sling device failure, the only way it's going to fail is if it's just not going to work in that person, or if it accidentally somehow slips off the urethra. The guy, fell down the stairs 2 weeks post-op and, did a split and it yanked off his urethra. The sphincters, typically we get about 6 or 8 years out of those. And what happens is the urethra underneath the cuff atrophies, and so it can't grip as well. So so that needs to be replaced, and they can be replaced without much difficulty. Next slide. insurance covered and not guaranteed. Medicare covers penile implants and artificial sphincters. I've actually never seen an incontinence procedure denied in all these years. That's 200 slings, 400 or 500 sphincters. I've never seen one denied. I had one that was denied, and I talked to them, and they said they thought that it was a penile implant, and that which would have been denied. And they said, oh no, an artificial sphincter is covered. So next. Stress incontinence is a known effect of prostate cancer treatment. There's a lot of options: sling sphincters, injections of coaptite, pelvic floor physical therapy, a lot of options. Next slide. That's it. We got through that all right. Nobody got hurt. So I've got the chat open. If you guys have any other questions, just fire them off now. And I'm happy to basically have an open discussion at this point. Oh, yeah, I might have skipped that. Life expectancy of penile implant. Average use, I think I said it, 10 to 12 years. And again, if it fails, what happens is the patient will come in and he'll say, hey, my implant's not working. I'll squeeze it and it'll do one of these numbers, and it's just got air in it. It's got a pinhole somewhere in it. You take the old one out, put a brand new one in, all parts, and you start over. Average use is once or twice a week, and most guys will get 10 to 12 solid years out of it. Is there an age limit for implants? The answer is no. I've put a penile implant in a guy who was 88. He's the oldest guy that I've implanted. Super spunky 88-year-old guy. Did walk 18 holes 3 times a week with a carry bag on his back. Had a new girlfriend. She was a younger girlfriend. So she was, I think, 70, and he did great. Let's see, pills take 2 to 5, depending on your body build, 145 pounds, fewer pills, a smaller body size. Well, the reason that we put those directions on that is basically you want to tailor that dose to you. So use the least amount of the pills as is effective for you. And so typically if it's 2 to 5, it's probably sildenafil. It's probably the 20 milligram sildenafil. I typically write that as 1 to 5. If one works for you, great. Not an issue there. If one's not enough, then you need 2, try 3, etc. Hope that answers that question. So it's basically, trying to figure out what you need. Yeah, for a 145-pound guy, depending on his health status, I would expect that he would need less. Premature ejaculation treatments. So the treatments that I'll use for premature ejaculation, we'll use, I recommend condoms, Promescent spray, which is available on Amazon or from MinMD in Florida. It's a xylocaine spray that works pretty well. I'll also recommend some of the SSRIs like Prozac, Paxil, Cymbalta, Zoloft, Lexapro is another one. Those drugs have side effect of delayed orgasm. I actually had somebody contact me the other day and asked about injections of hyaluronic acid into the glands, which I've never seen. And I have absolutely no idea how that could possibly do anything other than causing scar tissue, which would cause permanent desensitization of the glands, which I don't think anybody would want. So yeah, there are treatments for premature ejaculation. See that quite frequently. Not everybody is fixable from a prematurity standpoint. Most are, but not everybody. Does retrograde ejaculation affect the available options? No. Where your ejaculate goes, if you're post TURP, if it goes back in your bladder, it doesn't matter as far as ED treatments for that. Doesn't matter. What's the process to get an appointment, and is there a charge for an evaluation? Yeah, I would just, I'm happy to see you guys anytime. The main office number is 512-231-1444. And, you know, any evaluation that I do, I typically just bill that to people's insurance. If a patient is cash pay, I charge them the lowest visit that I can charge them, like a level 2 return visit or whatever. And then we sort of go from there. So minimal. Retrograde. Retrograde ejaculation treatment, not. Let's see. I'm trying to get the retrograde, not premature. Does retrograde ejaculation affect the available options? Yeah, I'd answer that. That's initial CT. Yeah, retrograde ejaculation does not affect the available options. The question right before yours was about premature ejaculation, which is why I talked about both of them. Happy to do this. Yeah, retrograde. Yeah, you have, another guy, testosterone for women. Yeah, pretty common. I probably have 100 women in my practice that I give testosterone to, you know, ballpark, maybe more than that. I've got 2 or 3 partners that treat women as well. It's pretty common. It's pretty common. If you ask an endocrinologist, they'll want to like get naked and jump off of a building, you know, giving testosterone to a woman, but it works great. And side effects are limited. We watch for acne in women. We watch for hair growth, you know, facial hair growth. Sometimes you'll see clitoral enlargement, depending on how big the dose is. But yeah, it's actually pretty common, and it works great. And we, let's see, got a guy named Robert who has his hand raised. Robert, if you can just type any questions into the little chat box, just click on the chat that's right there on the bottom of the screen. And if you want to type your question, I'm happy to answer it. All right, well, if there's nothing else that you guys can think of, I guess we can shut it down for the night. Like I said, I'm happy to see anybody anytime. Sometimes it's a tiny bit tough to get an appointment with me, but you know, comprehensive consult for whatever your issues are is always eye-opening. And again, I think a lot of times guys kind of give up on what their issue is. It's kind of depressing. I think that I try to do a really good job of just explaining to people, hey, look, you know, these issues they're almost always fixable, you know, and here's the options. What do we want to try? And then we take you down that pathway. Once that's done, the satisfaction rates are super, super high. I tell young people coming into practice, just listen to the patients. They're going to tell you every single time exactly what they need. Just listen to them. So that's it. So I appreciate you guys attending. We had a great attendance tonight. If you guys want to get in touch with me, it's urologyaustin.com, or our office number, our main office number is 512-231-1444. Thanks, guys. You guys have a good night.